You are tuned into the Dr. Tina Show with Dr. Tina Moore. For more, visit drtyna.com. Sandra Bargeron, thank you so much for coming on the Dr. Tina Show and making the trip out. I'm so excited to talk to you about your book, about, we're going to talk about general anesthesia.
Yeah, general, or would you like to talk about the entire
The whole thing.
Okay.
Yeah, the
there's a lot to say.
You're the expert, and I found you on Instagram many months ago, and I was so excited that you exist and that the work you're doing exists, because it is a needed place. My backstory is that I vehemently do not love anesthesia. I was taught early on by my mentor to stay away from it if I could. Mm-hmm. And we were talking offline. When I bring this up with people, they freak out, which I'm sure you're very,
very familiar with that experience.
So anyway, tell us about yourself and we'll dive in.
Yeah. So I guess I'll give you kind of the background how I landed in a kind of a social media space, even talking about this. But basically, I come from a medical background, but prior to that, I was a fitness trainer. So I did have a little bit of holistic mindset, nutrition mindset. I had a certification, all that jazz. I paid my way through PA school doing that. But I chose PA school partly because my father-in-law told me not to go to medical school and that he didn't like how medicine was going with insurance and everything. And partly because I also wanted to split my time as a mother. So I chose PA school. So that was 2004 when I graduated from PA school and fully indoctrinated in the concept of medicine is the only way really to heal the body. And it was kind of surprising because I did have a little bit more background to that. I don't know how I ended up thinking that was the only way. But at the time, 2004, it was not so common to meet a naturopath. And chiropractics were also pretty rare. All that was a pretty rare experience for me. So I went into medicine wide-eyed. I was, I think, 24 when I started practicing. So don't do the math. It was 2004. Don't do the math. But it's been a long time. And I quickly started to dislike the paradigm in medicine. It was very obvious we either operated or we band-aided with medications. And those medications didn't come benignly without any side effects. So there were always side effects that led to more medications. And it was 2 years. So I was kind of grateful that I didn't go to medical school and have invested as much as it would have taken to do that. But I didn't know what else to do with myself because I love taking care of patients. I really love to take care of the body. I love the science of the body. I loved it all, except I hated that whole system of band-aiding, not really fixing it. So I made a transition into anesthesia school. That was about 6 years into my career. And then I got a master's degree in anesthesia. I'm a certified anesthesiologist assistant, similar to a certified registered nurse anesthetist, CRNA, same anesthetist category. And it has been very good because I love taking care of patients immediately and taking away their pain and taking away their suffering. And I could live with myself at night because I knew I was giving medications that I felt were relatively benign, short-term, no long-term use. Over that experience of 2004 to onward, I've had 5 children. So
wow.
I had 5 children. And
you look fantastic.
Oh, thank you.
Good job.
So as motherhood humbles you and teaches you, I had to learn a lot of things. And also along that pathway, my mother-in-law had sudden open heart surgery. And it changed her personality dramatically overnight. And we didn't expect it. We didn't know that was going to happen. We just knew she had cardiac issues, family history, and we needed to do this open heart surgery right away. When she came back, she was not herself. And she was just, I think, 69 years old. It wasn't like she was very old. And it was a slow, steady erosion of her personality and her being. And I never would have, I still didn't connect it at the time to the anesthetic or to even the surgical event. She always said, oh, my memory's slipping. So I just thought, well, maybe her memory's slipping. Until I started to look at the literature in anesthesia, which we're introduced to somewhat in anesthesia school, but we only look at it for how do we manipulate anesthesia in a way if there's a high-risk patient. Mm-hmm. We don't look beyond it really in the demographic of does this have impacts beyond what I can do anything about right here in this OR suite. So it kind of was dissatisfying to me. Meanwhile, my son, so I had 4 boys and 1 girl. And my oldest was extremely ADHD. And I call him kind of the victim of my medical training because he got everything medicine, told me to give my kids every antibiotic multiple times, and ADHD profound and all this, amphetamines with that, at 5 years old. It was terrible. And so by the time my 3rd son came around and had symptoms like that, I was like, we're changing our diet. We're doing something different. I'm looking a little differently at this situation. And so we looked at diet, we changed his diet, and things got better. But once that settled and those symptoms of ADHD started to kind of settle down, he had symptoms of joint pain and tummy aches and neck pain and headaches that were this weird constellation of symptoms that kids don't complain about. And this is an outdoor kid who doesn't complain. He just wants to play, right? He's an active kid, 6 years old. And then he had an anesthetic. And as, kids do, playing around with any foreign object in their mouth. I don't know why they do it at 6 years old. They threw a quarter and a nickel in his mouth, and it got lodged in his esophagus.
Oh, no.
Yeah. So, and it was
What
stuck.
are the chances?
And it wasn't moving. So, yeah, it was awful. And he was in a lot of pain because it would just peristalse every time, and it get stuck and cause like horrible pain, and then it would get better. And anyway, it took him a while to tell us what he did, and we ended up in the operating room for a very brief anesthetic. I mean, I did these all the time. It was literally 5 minutes. But when he woke up, his color was different. He just looked different. He acted different. Every symptom he had before that was worse. And his ADHD came back full force. And I was like, what is this? I still didn't make connections with anesthesia. I figured out that what happened here was an exposure to Lyme disease. And I didn't even connect it to the anesthetic at the time, that we basically unearthed that. He already had it. Mm-hmm. That we unearthed it with the stress of the anesthetic and the procedure. So all I did was this rabbit trail down Lyme disease. And as a researcher, as you can imagine, and as you well know, Lyme is probably the most complex thing that we deal with in functional medicine.
Bioweapon?
Yeah.
We can maybe
exactly.
edit that.
Yeah. So it took a lot of research, and even that was kind of mind-blowing, like exactly what, like tracing it down. Where does this come from? Why does it act like syphilis? What in the world? I don't understand. What are these labs? And then I fell into functional medicine as a result because I needed to understand what my doctors were talking about. And I've got 2 medical degrees. I can figure this stuff out. So I did more research and ended up getting, my PhD. But basically it was my son suffering because he, at the lowest of his symptoms, he was unable to walk. 6, 7, 8 years old, we were carrying him up the stairs.
Wow.
Now, we lived in Georgia at the time. That's known for nice, humid, kind of tropical, but unfortunately, it's also, with humidity comes mold. And we could not get him well because the mold that was ubiquitous in the environment kind of made his immune system struggle. So we ended up moving our whole family to Colorado, which we wanted to live there anyway because we ski. But it took that and then, of course, intensive work to get him well, which we did do, and we did get him well. But it was that experience that made me, and the training that I had to get in that experience. So again, I'm circling this to a close, I promise. That made me look at anesthesia differently, because all of a sudden I was looking at methylation, and I was looking at this, and I was looking at that, and I was looking at resilience, and I was looking at the nervous system and neuroinflammation and microglial inflammation, and I was like, what about anesthesia? So that's how I ended up accidentally, through a series of orchestrated things over my lifetime, over 20 years, looking at anesthesia differently from a different lens, and not just, in the literature sense of what we have in anesthesia, but from a perspective of the whole person, like a holistic sense. So that's how I got here. And that's what ultimately led to the book.
I love it. Well, we usually end up on a personal, it's always a personal journey for ourselves or for our family that get us here, right? And so at the end of the day, I became a naturopathic physician intentionally. I did not want to become an MD. I had been on the path to become an ND or MD since I was a little kid. Like I remember being 5 years old thinking I was a really sick little kid. And I remember thinking there has to be a better way to do this with what I was being put through by the establishment. And, I ended up walking into a naturopathic physician's office and started as his receptionist. And I was like, what are you doing here?
Wow.
And
How old were you there?
I had just gotten out of undergrad. So I was like 23, I think,
wow.
22, 23 when I met him. And he was a naturopathic physician and an acupuncturist. And he was just doing magical stuff. It looked like magic to me,
Yeah.
And he would combine it all. He was chelating patients intravenously. He was doing prolotherapy and regenerative injection therapies. He was using a lot of acupuncture, and he was taking care of the sickest of the sick people. A lot of neuroinflammatory diseases and neurodegenerative diseases, and he was kind of famous for that. And people would come in wheelchairs, and within a few weeks to months, they were walking out themselves.
Magic.
And it was and that was it. Like I was like, that's it. And I had
what a blessing to catch that so early.
Oh yeah. Well, as a very sick child, the only doctors that ever answered my questions and really took care of me were my chiropractors. And so I was hell-bent on becoming a chiropractor, and he sort of intervened, and I ended up doing both. But it's a personal journey. And I really wanted to protect my
structure
family.
and function.
Yeah, and you want to protect your family, right? And your loved ones.
100%.
At the end of the day, like I became
100%.
I went through what I went through so that I can help navigate for my family.
Yeah.
And intervene when I need to, because it's the Wild West out there. If you don't have an advocate, who knows what's going on?
Yeah, I was just saying that to someone. I don't remember who the conversation, but it was like, man, really at least understanding the body well enough to kind of, and your body in context of your environment. Like being able to perceive that you have, your body works like this optimally, but when you put it in the context of a certain environment, that environment can impact how the body works optimally. And having your eyes open to that makes you more able to, advocate for yourself and optimize situations. For example, living in Georgia versus Colorado, there's mold in the environment. So you can pretend that there isn't or don't acknowledge it, or you can and go, okay, well, maybe I need an air doctor. Maybe I need a dehumidifier. And maybe I need to pay attention to the mold impacts on my body. When you walk into the operating room, that's one of the things I say all the time. Like, it's not just the anesthetic. It's a whole environmental exposure. Like, it's the whole exposure of the surgery. That's an environmental stressor on the body. And the body has to respond to that. And you have to have your eyes open, or you can pretend it isn't a problem. And, well, everybody else does fine, so I'll do fine. It's your choice. But when you're thinking, how do I advocate for myself? You really have to give yourself enough awareness of your own normal, healthy body, how it's supposed to function optimally, and what happens when we put it under the water or skydive or, there are dynamics we pay attention to when we do those extreme sports. We should do the same thing in our everyday life. That's how you maintain optimized health, right?
I agree. So the thing that caught me with your Instagram was you were talking about how anesthesia is a neurologic stress test. And do I have that right? And how it's a stress test for your brain. And I thought, oh my gosh, she's finally somebody, because there are a few people I've heard talk about anesthesia being a concern. And it's something that my mentor drilled into me early on. Like I said, like he was telling me back in my 20s, stay away from it if you can. Yeah. At least don't be flippant about it. It's not a casual thing like, oh, I'm going to go have this, aesthetic thing done to my face. And I know, gosh, the amount of people I know, if we were to count up their exposure, it's crazy.
Yep.
And you can definitely see a personality change.
Oh, yeah.
Or in my patients, I will see an aggravation of autoimmune disease. Yep. I may see an aggravation of things that we've gotten into remission and we've calmed down, and all of a sudden they crop back up. And I think the biggest one is kind of a dissociation along with a depression.
Oh, yeah.
That's something that I've seen numerous times in people, loved ones, patients, where they're just, like you said, they come back different. And it might even just be a quick exposure. I personally, the only general anesthesia that I can remember, I was 5. I had my tonsils out. That was probably not a great idea. And then I had to go under very briefly with the birth of my daughter. I only have one child, and my placenta would not come out. And so they had to just put me under for a second. He literally was like, there was an argument. The anesthesiologist was over me holding my head because I'd been vomiting the whole labor and delivery.
I love OB.
And he said, I can't knock her out. She's vomiting. And the OB guy said, I have to put my fist into her uterus. And so he said, I just need 30 seconds. And the guy looked at me and he said, you'll be fine. He turned my head and that was it. Like I was out and I came back.
Those are always the most the most scary experiences, and the ones that I hear the most about is like their emergency C-section, emergency around, delivery.
No decision making.
Yeah, no, it's because it's emergency. This is true emergency medicine, like happening right in front of you, and you are so helpless. So,
and I've had the most severe postpartum depression, and I always wondered how much of that was in part.
Oh yeah,
I know it wasn't the whole shebang, but
there's actually a study on that. I covered that in a reel because that's actually a similar experience that I had before anesthesia school, even before PA school. So I had my first child when I was 22. We started early, and I think my last one at 36. So it's a big gap.
That's a
big gap. Just
that's a good
PA school, anesthesia
frame.
school in between. Yeah, but my first one. And I worked with this anesthesiologist later, and I realized why he did that, and I was more angry about the situation than I was at the time. But I had a working epidural, and my son went into, D-cells and all these things that make them go, oh no, we got to go to the operating room, C-section if you're in the hospital. And so I rushed to the OR, and he put me to sleep. My epidural was completely working. I couldn't feel anything, but he put me to sleep. And I had postpartum depression for 2 solid years.
Wow.
I didn't know what it was until I was in school learning it, because I went right into PA school after having a baby. That's also not probably the best thing to do, but I was in there learning about postpartum depression. I was learning about the symptoms and signs, and I was having, it was getting worse because school was stressful. And I was like, I'm a happy, bubbly person. I really am. People used to call me Tigger. I was a fitness trainer, and so it wasn't me. It was a totally different shift. And I couldn't get out of bed at one point. And I realized, oh my gosh, I'm depressed. I took Wellbutrin and I felt better. And this is a time when it actually did do something good to take some medicine. But looking back at it, I looked at those studies, and it's something like 45% of patients who have to have general anesthesia will have for C-section will have a postpartum depression.
Really?
Versus like 10 to 12%. And I got to look the study up. So the statistics may not be perfect, but it's an uptick, huge uptick, closer to 50% when you're having a C-section under general versus epidural versus awake. And there was even so epidural's even impacted.
Yeah, there's an impact.
So it's something like 30% or 28% with an epidural and then 12% without anything.
So you're getting a double whammy.
So postpartum depression is going to happen because hormones shift and you lose all that progesterone when you lose your,
right.
But add to that the stress of surgery or the stress, of the epidural, the general anesthesia. It has impacts on the brain. It directly impacts the hippocampus. So 100%. That's a normal experience, and I'm sorry you went through it.
It makes me want to cry.
I know.
Like angry tears, because it was so bad. And it created such a disconnect between myself and my daughter.
Bonding, yeah.
And to this day, she's 26 years old, and there's still, I still beat myself up over those first few months because I couldn't function. And I had a history of depression, so everyone just blew it off as that, oh, it was worse, And if you go in, I'm kind of a low hormone girl, and I share this because I want everyone to hear it. We know also in the functional medicine space that if you are a low hormone girly and you walk in with low estradiol levels, your rate of
progesterone levels.
Yeah, and progesterone, your rate of postpartum is also high. So, it was a perfect storm, but I don't think that women, particularly, I was young, I was 24 when I had my daughter, 25, somewhere in there. You're scared.
Yeah, you don't know anything.
You don't advocate for yourself. No. The doctor is God, and you do whatever they say. Yeah. And you're having a baby for the first time, which is terrifying in and of itself. So this is information I want to get out because the more we know. Yeah.
Well, you actually give me a good piggyback too, because a lot of people, I get this question all the time on Instagram, so should I just do an epidural, or shouldn't we just do everything on spinal? And I actually have a pretty shocking statistic from 2 studies. And I need to I want to pull it up because I don't want to get the information wrong, but the name of the studies, they're the 2 R's is what I call them. The Regain study and the RAGA study. Okay. Both of those looked at hip fractures. Okay. Hip fractures alone are bad. We don't want anybody to have a hip fracture. So work out, women.
You go to the gym, do your squat.
Yeah, because it's just really hard on the body. But they did what they did here. I'll read it directly. There was 1,800 people in the Regain study. Okay, they were 50 and older, so that doesn't mean they're just over 70. And if you had a spinal, you had a risk of delirium of 20.5%. Okay, if you had general anesthesia, it was 19.1.
Wow.
So to answer the question, is regional versus general better? Not according to the Regain study. And then the follow-up study was the RAGA study. It was 950 patients, 65 and older. And the same thing, we had delirium the first week is 6.2% in the regional group. There was 29 people that out of 471 that got delirium in the first week. And then 24 out of 70 had general anesthesia and they had delirium.
Wow.
So again, it's not perfect to say, let's just avoid the general anesthetic. You have to understand there's still an impact of both the regional medications, and it's probably beyond the scope of this podcast, what this is. I actually went down a rabbit hole for my book to understand what is the impact of a regional at this level, this level, this level, and this level, like different levels of blockage of the spine. As a chiropractor, you can imagine, what does that physiologically do? Now add the surgical stress.
Right.
Inflammation, priming, immune priming, all the things. Those don't happen in a vacuum. You block the adrenals at T4, and below. So, what happens when you're blocking the adrenals and then shooting up surgical stress because you're doing an incision. There's an impact on the nervous system from just that, not just the drug. So it's it's a really important piece to remember that it's not just the anesthetic, it's the entire experience. That's why it's a neurologic stress test. The whole thing is.
So 2 things. One, you're injecting drugs into the nervous system at different layers. So that's a big deal.
Yep.
And then 2, you make such a good point. People don't realize that. I had an upper bleph 2 Novembers ago. It was just local anesthetic. I was awake, excised some tissue, sew me up. I had the craziest autoimmune flare after that. And my eyes would not stop swelling. And I jokingly tell my husband, that ruined my life for a blip. It was, all my friends just whizzed through it, but I'm sitting at this age where I'm 52. At the time I was 50. So your hormones are shifting, your immune system's activated. I'm an autoimmune girl. I went into a flare. I'm swelly. I'm just that middle-aged swelly girl, everything. I didn't used to swell up all the time, but I swell up all the time. And it was such a profound
response.
And I was shocked. And I was even talking to him the other night. I'm like, I am shocked at the fact that the incisions still itch and what a tailspin it put me into. It was like a downward spiral for several months. And I was also at this pinnacle of stress and I had a lot going on, but just even that. And then I was recently in the hospital with my mom and I was talking to a nurse and she was telling me about how they're giving orthopedic patients opioids prior to starting the surgery because even though they are, asleep, and we'll talk more about that because you were talking about how their brain's in like a comatose state. Even though they're asleep, they're still experiencing the pain and they're realizing the just tremendous impact that that's having on patients post-surgery. And so there's just all these variables that we don't even think about. But having even a mole excised off of you or getting a tattoo, it puts you into a spin if your immune system's primed for that. So,
and the autonomic nervous system is still active even if your central nervous system isn't. I had a similar experience when I was working in orthopedic, joint, spine, and all that stuff. We did cervical spine fusion, all this. And I was a PA. I was having carpal tunnel from all the surgical. And my surgeon went to his partner and said, hey, would you do her carpal tunnel surgery at her lunch break so she can keep operating?
Wow.
And I was like, okay, that sounds good. So I, finished clinic, and then I went to the operating room 15 minutes later, local anesthesia, not asleep, had my carpal tunnel done. I got in the car, drove to my house, which was 5 minutes away, got out of the car and passed out.
Oh, yeah.
Because autonomic response. And I wasn't nervous in the I work in the operating. I operated on people at the time. I was like, what is going on? What is this? It's an autonomic response. And you can be completely asleep, but still experience it. And as many researchers in the psychology world have proven, the body keeps the score. I round the book up with a little bit of that trauma language, not to make people more scared or, anything weird, but the reality is it's not something we talk about in anesthesia. Every surgery is a trauma. The autonomic nervous system experiences it, the nervous system experiences, and the body experiences it, and it remembers it. And in children, you put them through that several times, you see symptoms of PTSD. It's well documented because they've gone through, they don't have a construct to place this information. All they know is they wake up and they're in pain and they've been operated on over and over, right? And so it's a true medical PTSD experience. And it doesn't have, you can be treated perfectly and have the best care, and you still have that experience if you can't, place it properly like children. And even as adults, go through pain enough, have surgery enough, and it becomes sort of the body's internal response starts to be similar to a PTSD response. So it's not minor. It's not something you should go in haphazardly and uninformed. You should prepare. I'm not saying don't do surgery. I mean, like you were saying, so many people have surgery. It's actually, the average is 9 surgeries in a lifetime.
Wow.
So the average in America person will have 9 anesthetics in a lifetime. That's a lot. We do something like 40 to 50 million surgeries in America every year.
Wow.
That's a lot.
Well, and then you add on top just the casualness of facelifts that we're seeing right now. That is it's really getting popular. Just all these little aesthetic procedures here and there. The amount of women that I know who've had breast implant surgery, then they've had revisions, then they've had explant. I mean, it's just, and it's become normalized, and I'm not judging anyone and no shade, but all I think about when I hear about that is like, oh my God, how many times have you had to go under?
Right.
And what is the overall impact of that? It's not this casual bounce back kind of thing. People shift. I saw this. I want to talk about this because I think in the elderly, we're probably looking at, this has got to be devastating in our geriatric population.
Yes.
And it's just so, how do I say this? Medicare is such a way, at least I know in my world, I never took Medicare, but I knew many doctors who did, who were in the orthopedic community. And it is such a way that there is a way to work Medicare to get optimally reimbursed. And I get it because Medicare probably pays garbage and doctors have to get,
it's terrible.
But it seems like there's a casualness of doing surgery. It's almost like they're just flippant about it, doing surgery on these elderly folks. And the amount of times I've had to intervene for patients or my parents and be like, whoa, is like, how necessary is this? Because just the act of going under general anesthesia 100%. Or even the other, alternatives, this is going to be rough on them.
Right.
On their personality and on their brain overall. And are we inducing like low key dementia early on?
I want to answer that question, but I also want to piggyback on something you said there. And it's part of my main thesis because I get a lot of pushback. They're like, well, what are we supposed to do when you have to have surgery? I get that a lot.
I'm sure.
What am I supposed to do? We got to have surgery and, we're supposed to go back to the dark ages and not have anesthesia. And I'm like, that is not the purpose of my thesis. All my work is not about making people scared of anesthesia or avoid it. It's actually a modern miracle to be able to do anesthesia. Believe me, you do not want to go back to the way it was. And I don't think that anesthesia or surgery should be avoided when necessary or even when desired. The difference is I want people prepared.
Yes.
Right? And there is a way to prepare your nervous system. If it's a resilience problem, which the studies show, they show that it's a resilience problem. More and more studies are saying the frailty of the patient, their cognitive reserve, their neurologic resilience. These are the factors that matter more than the drug, more than the regional or general, more than any other factor. How is the brain walking into surgery? And so if that's the case, that's modifiable. You know what I mean? Yes, we lose resilience as we age. And that's why the statistics in the elderly population, like you were saying, are higher. So when we start looking at 65 and older, that's kind of our gold standard. We look at 65 and older as elderly in the anesthesia literature. And delirium can be as high as 40% in some of these cases, up to 70% in open heart surgery or really major surgeries, 70%. And then you have you're 3 times more likely to develop dementia if you develop delirium.
Wow.
So
3 times more likely to develop dementia if you develop delirium.
Right.
And so that's where your neurologic stress test comes in.
Correct.
So tell me real quick, I don't mean to interrupt you, but just for the audience to understand, what are kind of the signs and symptoms of delirium so they know what we're talking about here?
Delirium is a short-term change in cognition where it can look terrifying. They don't know their personality changes completely, like completely. They were friendly and loving. Now they're yelling at you and cussing. I have a classic example of my mother-in-law doing that. She was a delicate Southern belle. I mean, and I didn't make her happy one day, and she threw a 4-letter word at me, and I was like, what in the world? That's delirium, classic delirium. They don't know you. They're cussing. They're seeing things even. Like, they have no sense of time. They sometimes are, like, hallucinating. It's terrifying. I mean, it's terrifying for them afterwards, but it's more terrifying for the nursing staff and the family that as observing their loved one who was normal walking in and is completely out of their mind walking out. It's short-term and it resolves. That's the thing with delirium. But
how long? I mean,
and that's the
what if we're
range.
seeing this weeks later?
Yeah. So weeks later is different. It actually doesn't qualify for the diagnosis of delirium. That would be, I think, given a different diagnosis, I'm not sure where it would go. But delirium is usually, 24 hours to 7 days.
Okay.
Something short like that. Dementia, though, obviously is that slow erosion of their personality and their thinking, their memory, their everything. They lose themselves with dementia. And it breaks my heart. And this is I saw it happen with my mother-in-law. And it did break my heart because she was fun. She was a funny lady. She was I loved her. She's my mother-in-law, but I loved her, and to see her completely change to somebody she wasn't, I don't want that for anyone. And if it's preventable, which it is, and you have power over it, and you don't have to wait for the system to catch up, because believe me, the system knows and has tried and has proven they can do it. They just don't have the infrastructure to do it. Why wouldn't you do it? Why wouldn't you protect your brain? Surgery may be necessary, but if you can do something to build your resilience and protect yourself, why wouldn't you? That's my whole message.
That's my whole podcast platform and my whole online platform is to build resilience and to avoid frailty at all costs, because you don't know what you're going to have to walk into.
Correct.
And you don't know if it's going to be something. Is it an alternative or a surgery you can have an alternative to? Do you have to do it right now? Do you have to do it later? Is it an emergency? And I want to be prepared.
Right.
And I don't want to come out the other side less than I went in. My biggest fear in the world is losing my brain, because it's all like you. It's that's what we function on, right? That's how we make our living, and
it's who you are.
Yeah.
So you could be walking around a shell of yourself, dependent. And I mean, we don't want to lose ourselves.
So if folks go in with dementia, like that low key.
Oh, yeah.
It's so weird because in the medical world, I see low-key dementia and low-key frailty, and it's never charted. It's never acknowledged. It's just been normalized.
Yeah.
My mom's entire medical chart going through that, I had access to it on the back end, and not once did somebody mention frailty. And I'm like, are you kidding me? Like, to me, that's a vital sign for everything that we're going to do and everything that she's going to be able to handle moving forward is what is her musculoskeletal state. And I mean, your muscle mass is a vital sign.
It is.
And there was no discussion of even post-procedure cognition.
Right.
So not necessarily delirium, but anything. It was so weird to me about how little emphasis they put on even the ability to get up and use the restroom by herself. Like that to me should have been something that was charted daily.
Yeah.
As just a baseline of like, okay, we've got improvement. And none of it was. And I feel like it's almost intentional.
It's a system problem where there's not a code for something. There's not a motivation for it. I'm trying to phrase that properly. There's no code for postoperative management. So you can't capture and you can't give it to anybody to do. You can't assign the duty. Anesthesia is the one that's responsible ultimately for like, how do we optimize the situation? I'll give you an example of that in a minute. But the positive impacts are felt by other people. And it's really not inside the realm of anesthesia's scope of practice to be able to manage the infrastructure it needs to build to be able to properly provide that. We were saying this earlier, like pre-op is your primary care doctor or cardiologist clearing you for surgery. Anesthesia is really concerned about keeping you alive, keeping you safe, keeping your blood pressure good, making sure you don't have a stroke, making sure you don't have a heart attack, making sure everything is really, really smooth. You don't wake up throwing up, having pain. Like we do care. Anesthesiologists, the whole specialty is very research focused and always looking for a way to improve safety, kind of like the FAA. But that's the limitation of where it stops. Afterwards, it's the surgeon you're following up with, and there's no one assigned to that infrastructure. And the interesting thing that you said, there was no cognitive question there. The Wall Street Journal published an article in 2016 saying brain measurement is coming. Brain measurement to preoperatively is coming, 2016. And that was because it was piggybacking on the body of research we already had saying cognitive reserve is a problem. If it's low cognitive reserve, then we have more of a risk. And what medicine is really good at is identifying a diagnosis and a risk. So what we have when it comes to testing is cognitive assessment tests. Your neuropsychologist or your psychologist, they're going to do a cognitive assessment, mini-cog, all these things, MoCA scores, all that. That gives you a score of where you're at, okay? That's not giving you anything modifiable. It's just saying you're below baseline, you're at risk. And that's what they were talking about. And they understood that if you had a low score on these tests, that you would have a higher risk after surgery for delirium dementia. 10 years later, we did a study that polled 1,700 anesthesiologists and asked them, how many of you guys see cognitive assessment tests in your patients pre-op? 1 in 10.
Wow. So that would be on the physician who's
looking,
clearing them for surgery.
No, it was the anesthesiologist looking at the patient, so we see them pre-op. We see them the day of surgery.
Oh, I see. Okay. You do see them pre-op generally?
Yeah.
Okay.
And within the people that they normally took care of, 1 in 10 reported seeing. 1 in 10 anesthesiologists reported seeing a cognitive assessment of any sort preoperatively on a patient that was even considered a high risk, 65 and older. So that's pretty significant given the fact that 10 years before that, actually 17 years before that, right? The New England Journal of Medicine in 1999 published that study that we were talking about earlier. It was done by Yale, and it basically took a population and that was at risk, 65 and older, and it looked at them and said, okay, we're going to take a multidisciplinary approach following surgery. We're going to give you light. We're going to make the environment better. We're going to give you massages instead of sedative pills. We're going to get literally that kind of stuff, like nutrition. We're going to follow the nutrition. We're going to really focus on these things in this population. They dropped delirium 40% in that population. 40%. This is a study in 1999. I want you to emphasize that because they already knew then that if we did these this is just post-op. This is not, we didn't even talk about preparation. We're just saying if we do that, we're already improving scores. They showed a economic impact of $7.3 million in the 90s, like cost savings for a hospital. That's a large incentive. And so it goes to show you that even if you have the data to support it, it's in the New England Journal of Medicine, you have economic benefits that are proven, the infrastructure is still not, you're not going to scale a change like that in the infrastructure because of the limitations of the system,
Yeah.
the Medicare system, the coding system, just the infrastructure of medicine. It's not designed for it. But what you can scale is a person who understands it, learns it, and has the support from practitioners who are also well educated on it to help guide them and protect them, prevention and follow-up. So that's my hope.
I love that so much because there's so much we can do. I was taught very early on by my mentor that you can absolutely prepare a patient for surgery. And we start months in advance if we know the surgery's coming. And the longer the runway, the better.
100%.
But really, you're training for it.
You are.
You literally are training for surgery so that you can fly through it and come out the other side and bounce back quickly. And I mean, he taught me that back in the 90s. And it's not anything, I really thought it would catch on.
Yeah.
And you literally were the first person I heard talking about this after how many decades? And I remember seeing your Instagram and literally like, is somebody really finally talking about this now and getting some, headway? Because it's crazy.
Well, I can only thank my son's Lyme disease because it was understanding the complexity of the nervous system from beyond what I was taught in medicine, from the bigger scope of functional medicine. That helped me understand that resilience was this factor that we can modify. The reason you don't have an anesthesiologist talking about it is because if they bring this up to the public without anything to offer you, all they've done is fearmonger, which I get accused of when I tell people, I'm not fearmonger. I'm giving you the tools, but they get accused of fearmongering, and fear is something you want to avoid. Look, anesthesiologists, a lot of times in the profession, we screen these personalities into the field that are not just the smartest of the smart, because you got to do crazy math calculations on the spot, but also for personalities that can go with the flow, can make patients feel at ease, because when they're coming to you, they're freaking out, right? And fear, we know, drives cortisol up. And we know that in medicine, so we're not going to want you freaking out before surgery. So why would an anesthesiologist come on Instagram and tell you the truth about the scenario if there's nothing to offer but fear? Do you see what I'm saying? So I think it has been out of a goodness of desire to protect people. But I still don't think it's fair when patients walk in blind and they don't know that there's a risk. So I've always struggled. I knew this issue for a while, but it wasn't until I was like, if I can't offer somebody something, why am I going to even mention it? This isn't nice. It's scary. Like, my whole profession is designed to protect you and make you feel better, not make you scared. But if there is a solution, then it's not fear, it's empowerment.
Yes. And you have a tool, you have a quiz.
Yeah.
Talk about that.
It's, I shy away from the phrase quiz because it's actually a clinician design tool that I am trying to actually back. I have already the white paper written, and I have a whole advisory board reviewing that, anesthesiologist, surgeon, neuropsychologist, from the data that I've already received from the first cohort, which is now exceeding 5,000 people, which is really great. The follow-up is coming, which is a postoperative assessment tool that will help us to make better correlations between what does resilience look like after and what does it look like for you. What does that mean? What is the translation for that postoperatively? So it gives us more of a full orb of the view of neuroresilience to outcomes. And I'm certainly working on funding for that. So it's a true instrument that I would like to see hospitals use, honestly. But I'm not waiting for them because, again, as the study in 1999 shows, you can have the tools, you can have the whole system. It's more than a quarter of a century since that study came out.
Are we that old? So it's been that long.
If I wait for the hospitals to implement the system, which they had in 1999, then we're waiting. The average, and I don't want to misquote the name. I think it was the Royal Journal of Royal, I don't know, it was a British journal. But they have a study that showed that from implementation, like we find research, for only 14% of the research ever makes it to application to patients. And it takes 17 years on average for that to happen. Yeah. We're at 27 here with the New England Journal of Medicine, right? If I'm waiting for the system to kind of orient itself when there isn't any financial incentive, at least a way to document with Medicare, coding and all that stuff, then we're just going to be waiting forever. And people's lives and brains are impacted by that. And I'm giving it to the patient so they can do it.
Yes.
So it's free. You can do it yourself, and build that knowledge and understanding. And then the book provides a framework. It gives you like a view of all the factors to look at. It's a little intimidating. It's comprehensive. And believe me, it was hard for me to summarize a book that was this big, which is what my anesthesia textbook looks like, and functional medicine books that are not any smaller, into that, so, but it's meant to be a comprehensive framework so you can take it. Like I told my publisher, I said, I want it to be the what to expect when you're expecting surgery, because that's comprehensive, right? And
that's a big book.
That's a big book too. Yeah. So anyway, I hope that answers the question.
Well, I say quiz because I remember when I first got into medical school and it was an assessment tool for the practitioner. And I thought it was like a tool, I was like, what is this? And then you come to find out it's a series of questions that, patients can often access online themselves now. And I think it's empowering to be able to go through something and kind of see where you land, right? Like just get an idea. And I'm constantly beating the drum on avoiding frailty, like I mentioned, avoiding sarcopenia, avoiding being, since COVID days, I was like, you guys, you're not a sitting duck. If you are walking into this frail and inflamed, we're going to have a problem. And
100%.
Frailty is the kiss of death.
It's literally in the literature. The medical studies say it.
Yeah. If you
anesthesia studies confirm you.
Anything with frailty, you are in trouble. And so being able to have tools to assess yourself early on, and people don't want to think that they're frail. And I see frailty in 30-year-olds. I see frailty 100%. In teenagers, who are just 100%. Playing video games, sitting inside all day, never did any sports or athletics or outside time. And it's just endemic in our population now. And I feel like most of the people I pass on the street, I feel like I could push them over, and I'm not even that big, know?
Yeah.
So I go
Thank you, Twiggy.
I know. I go to the gym and I see a massive amount of middle-aged women thinking that they're lifting weights, and they're just dinking around with tiny dumbbells. And I'm like, you're literally wasting your reps.
What was it? My mother-in-law did this circuit training that was really popular back then. What was that thing?
Jazzercise?
And no, it was like they go to the thing. Oh, gosh darn it.
Was it Orange Theory?
It was pre-Orange Theory.
Oh.
It was like, she was like, I'm doing my blah, blah, blah.
Yeah.
And that's all they're doing is circuit training with light weights.
It's such a waste of reps. And I'm glad they're moving, and I'm glad they're trying.
Yes.
But without hitting the edge of progressive overload, you're literally wasting reps. And it's, it's a long physiologic explanation why. But at the end of the day, I'm like, if you're not, and they're all focused on their arms. They all just want to have the sinewy, thin Demi Moore arms. And they have dieted themselves into literally no butt, no hips. They are straight as a board like a little boy. They look like little boys, but they're 60. And I'm over here like grunting out the squats and the deadlifts and the RDLs, because I'm like, if you don't have an ugly, grunty face for lower body moves, what are you even doing?
Exactly.
Like, why are you even here?
The muscle is a metabolically active organ.
Yes.
It's a metabolically active organ, and it does make every bit of difference on how strong that is walking into surgery. To your point, in the OR, I have commonly commented in my experience, especially, I've worked in two very different states, Georgia and Colorado. Those are very different groups of people coming to the operating
health difference.
But what I see is that these older patients, I'm talking about 85 and older, if they're in the operating room, those guys are actually pretty dang robust. They're there because they have to be. Maybe they broke an ankle but when I look at their chart and I look at them and I listen to them, these guys are healthier than some of my 30-year-olds. Some of my 30-year-olds that are coming to the hospital have lists of medications this long, and they're just barely functioning in the world. And I'm like, what is happening in our world that we're so off kilter, and that 85 and older can be more robust than 30? It's not right. Something's wrong. We're messaging something wrong, But
I think that the younger generation thinks there's some miracle medication or pill that's, I think we saw that again with COVID, people were like, well, why can't you pull them out of the cytokine storm? Why can't you fix this?
Right.
And I'm like,
because that's modulated by natural means, not by a drug. And that's kind of my point too. I said one of my most popular reels that went kind of viral-ish was introducing a concept called postoperative cognitive dysfunction, which is recognized by the American Society of Anesthesiologists and the AARP. And we know this is a reality. And that's actually the group that's younger than 65. Postoperative delirium, now granted, you can be 65 and older and have postoperative cognitive dysfunction, but it's the subtle changes in the younger population, the disassociation that you said, the personality changes, the depression, the memory shifts that you're too young to have brain farts and memory problems. Like, what is going on? And it just lasts and it just lasts and it just lasts. It's postoperative cognitive dysfunction. And it doesn't get a diagnosis and it doesn't get any kind of recognition because of it being so subtle. There's no diagnostic code. But one of the things I said there was the gap. Even if we catch it, even if we diagnose it, what are we going to do with it?
Right.
People are like, okay, so can I demand to see the anesthesiologist was the answer to that. I'm like, no. First of all, the profession isn't designed that way. Second of all, if they see you, they're going to refer you because that's not what anesthesia doesn't do, neurology.
Yes.
Okay. So, now you go to a neurologist. What do you think a neurologist is going to do for you? They're going to do a battery of tests and they may do some physical therapy, but they're probably likely going to put you on a medication.
Yeah.
For a medication problem.
Yeah.
So there's a huge gap in what we can offer in medicine, even for this problem. So back to the NSRI, the goal here is to identify modifiable things that you can do. The Neurologic Stress and Recovery Index it's 5 domains currently. I'm adding a 6th because I missed something really important that will strengthen it. And the reason it was missed is because it's siloed. It's part of dental health. So dental health actually plays a role in cognitive health. But I didn't look at it. And actually medicine hasn't looked at it at all. It's not in any of the anesthesia literature. It's why I missed it. But I have oral health issues. So I thought, we're going to look at this literature, see if there's anything here that we can modify there. And so that's getting an add-on to the NSRI. But currently, the 5 domains that are in there, which is medication burden, your sleep burden, your lifestyle, your brain and social health, like how active are you? Do you have a community? These are things that you can modify. If your medication burden is high and you have a lot of drugs that are potentially going to interact with your brain and lower your resilience before anesthesia, you need to talk to your anesthesiologist or preferably your primary care prescribing doctor who can look at that profile and potentially give you some alternatives, or wean you off or change your direction, maybe change the drug even, because there are drugs that are better for the brain than others, right? So that's kind of the goal of the thing is every bit of this assessment is meant to give you a score to identify not where we're not diagnosing anything, where we are not predicting anything. We're identifying things that are completely modifiable that you have in your own ability to modify and strengthen. We're trying to find what you can strengthen.
I love it.
It's totally different.
Speaking of strength, I have 2 questions. One, what have you seen with folks of any age? Because you mentioned those tough old guys. My husband and I just spent the past many years on his farm. And I grew up in the suburbs. Those rural farmer men, they're all skinny and not very well muscled from the outside, but man, those guys are strong. They live forever.
Yeah.
They have very few health. I was shocked at the lack of health issues. I mean, aside from all of them having gnarly tractor accidents.
Yeah.
Or some kind of getting
or sometimes tick-borne illness.
losing a finger or something, but really durable, resilient crew.
Oh, yeah. They're outside. They're grounding. They're sunlight. They're active.
all day through all the seasons too. So they've got temperature regulation.
Yeah.
Your ability to handle temperatures is a direct measurement of your vitality. I'm certain of it.
It's just because it's another one of those positive stressors, right?
Yeah.
We do things that are hard.
Hormetic.
Anything that we do hard for the brain, like read the book. Like, that's hard. You're gonna complain because it's thick or whatever. But anything you do, it absolutely reaps benefits. There's plenty of studies to support that, and the same for the body. That's why the whole cold plunges is a big thing. And yeah, like you said, temperature regulation, all that.
So what have you seen so far as folks going into surgery and needing anesthesia of any type who are well muscled?
So it depends on the age. So when we're talking about well-muscled young men, and we don't fully understand why this happens, but I think it has a little bit to do with hormones. Young men, I would say under the age of 30, well-muscled, they wake up very delirious.
Really?
Mm-hmm.
Do you think
I think they have a heightened fight or flight response because of strong hormone balance. We really have studies in anesthesia to understand it. We just know that it happens and we're ready.
I wonder sometimes though and I might be totally off here, I'm just thinking physiologically, doesn't the anesthesia sometimes end up in your fat?
Oh no, you're right.
And if they don't have enough, because I know that folks that are very obese, it's hard to get them out, isn't it? Because would it be maybe because they're too lean?
That is actually, you're not wrong, and your logic is very sound. It is partly because of that. I would estimate that it's partly because of that, because the on and off is faster. And imagine if you're completely sleeping and happy, and then all of a sudden you're awakened where am I? And you're a man, and your natural defense or your natural position is to protect and defend.
Yeah.
You're going to wake up and you're going to protect and defend. I have had that experience many times. I remember one patient woke up. I took over the case, so I didn't even have time to tweak the anesthesia, okay, this is a young guy. We're going to do some things. So I walked in and I ended up waking him up. And it took the entire OR staff in that room, plus the OR staff that was hanging. I mean, we had, I kid you not, 10 people on every limb while I was scrambling to try to give more anesthetic to put him back to sleep because he was waking up like the Hulk, no kidding. But that's kind of a common experience in some young men. But older men, they do tend to flare. Your men, are you asking men specifically?
Well, just in general, I just wonder if people who are metabolically optimized wouldn't do better.
Absolutely,
overall.
they do better.
That's what I'm getting at.
Yeah, so metabolic optimization is 100% a huge piece of it. That's why lifestyle is a domain in the NSRI, because like you said, muscle is a bioactive organ, and it's a resilience organ. And your stress and hormone responses based on how much muscle you actually have are more resilient. They come back to baseline faster. So overall, I do feel like they do better. We don't have any studies to show that, but this is me speaking as a person with both perspectives.
Yeah, it's just the experience you've had.
Yeah.
Because when I was doing regenerative injection therapies on patients, the ones who it didn't even matter if their diet was garbage and they were sucking down Mountain Dews.
Right.
If they had good muscle mass and they were metabolically optimized, they healed so much more predictably. I could tell them with good faith that they were a good candidate and that they were going to come through it well. Versus, which is my next question, you're kind of puffy, deconditioned, metabolically busted middle-aged woman. Mm-hmm. Those women did not, it was a total crapshoot as to how they were going to respond to therapy and if they were going to be better at the end of it or if they were going to flare and it was going to be a hot mess for a minute. So that's my question. We know through different studies that have come out in the last few years that the brain in menopause is shifting, that perimenopausal, menopausal brain shift, and our brains are shrinking and reorganizing. And hopefully, I'm praying, knock on wood, when I get on the other side of this, it will all balance out because it's not that fun. Is that a particularly vulnerable time to receive anesthesia?
Yeah, that was another one of those viral Instagrams. I went viral on Instagram and TikTok because I said the top 3 most vulnerable are postmenopausal, perimenopausal, and neurodivergent women.
Oh, yeah.
Or women, postmenopausal, menopausal women, and the neurodivergent population.
Yeah.
This is outside of, 65 and older, period.
Yeah.
But if we're talking about the ones that you don't know, the population most people aren't thinking about, we certainly aren't talking about. The autism community is talking about anesthesia. But anesthesia is not talking about the autism community. Do you see what I'm saying? Mm-hmm. Like they know that, and they have support groups and studies and reports and protocols. Autism community does, but anesthesia doesn't. And I think that's weird, for one. But the women, this is a really complex situation. Perimenopause, even postmenopause. Perimenopause is worse because, as you know, that as the estrogen decline, it spikes, it drops, it spikes, it drops. As it's declining, it spikes. So you never know if you're on a estrogen dominant day or estrogen low day. So this is not the fun. This is really hard because that impacts detox, right?
Yeah.
Where's your estrogen? Is it high or low? As you know, PCOS is a high dominant state. Your detox pathways go crap on PCOS. Mm-hmm. That can temporarily occur in a perimenopausal woman. Yep. On top of that, the first hormone to decline is progesterone. And progesterone is active in a lot of the pathways in the liver to conjugate things and move things. And so when you already have a declined progesterone is dropped while you're doing this, your detox is jacked. So when we're talking, and then also what else happens with this? Swings in cortisol happen when estrogens. So we're not just talking about detoxing anesthesia as a problem. That is a problem. It is slowed. Your bile doesn't conjugate as well. You get more gallstones. You get all the things. But you also swing higher in cortisol. And that means that you slow everything. Your immune response is slower, your healing time is slower, and your brain's recovery is slower. Mm-hmm. So it's all a huge mess during perimenopause. And those are the women that I feel get overlooked the most. And they're in the crunch phase. This really, as a perimenopausal woman, I care about this because not only are your brain impacted and your life impacted as a result of it, but you are probably also caring for an older parent or about to be, and at the same time caring for kids. You're like the sandwich, generation, 40 to 50. You're caring on both spectrums for people. And now your cognitive impacts that might not be considered severe enough for a diagnosis are significant enough to make you not able to do those things. Do you know what I mean? Mm-hmm. And maintain your job and go to, work out and have friends and, all the things.
Hit your protein macros.
Yeah, right.
Get your sleep.
Right.
Well, your sleep's really disrupted through all that too, which is going to impact everything.
Sleep domain.
Yeah. Yeah, and your metabolic health is going to hell in a handbasket, whether you like it or not, and your pain is going to be more pronounced because it's the swings in estrogen that make pain worse.
100%.
So you're going to have a potentially more pronounced pain response. I think that's what was happening when I had that silly upper bluff episode. My cortisol was sky high. My estrogen was all over the place. Mm-hmm. It just was a perfect storm. I just wasn't in the right... If I had done it 3 years earlier or maybe 3 years later, but I was just in that perfect place. And that was enough for me to be like, I am not going to elect to have any surgeries if I can avoid them, or I'm going to put them off until I get through this little roller coaster.
Yeah. It's significant, but this doesn't get much press at all in the anesthesia literature because we silo things. Why we do look at dementia because we're doing something to the brain, but we're not looking at hormones. Like anesthesia's not looking at hormones. Believe me. I've polled my own colleagues, and they're like,
"Yeah, they're like, we got enough to worry about." Remember,
they're the ones having surgery. They're getting their gallbladder out because of hormones.
Yes. Oh my goodness. Yes. That's a tough one. And I feel like that is a very high orthopedic surgery age cohort as well, because the joints start to...
It's the shoulder. It's your estrogen. So fix the estrogen and get some progesterone. Just wait. Don't have the surgery on your shoulder.
I know.
Just wait.
That's who ended up in my office after the surgery. And it was like 9 times out of 10, I had to tell these women, look, you need 90 days minimum of HRT. It takes me 90 days minimum on top of that just to onboard the HRT appropriately because it's a slow process. It's not like, let me give you everything all at once. Good luck.
That's right.
And I mean, it's a process. I will tell you, it would probably take me 9 months to get somebody up to snuff if we were really doing it right. Because prior to that, I've got to get their gut health in check. I've got to make sure they're exercising and they're building muscle. I have to get their diet dialed in. 9 times out of 10, I have to get them pooping every day.
Oh, yeah.
And just basic level hydration. I swear, that's 9/10 of what I do is getting people to poop every day and basic level hydration. Yeah. And it's this whole long process. And then we're ready. Right. Then we're ready to do the thing. And people don't want to hear that. They want the quick.
It's the easy button, and a lot of the podcasts that I've heard other people bring out, they are looking kind of from a perspective of biohacking their way out of the impacts of anesthesia. That's sort of the degree, at least the perspective I've heard coming from other podcasters. And I don't know if it's just because they haven't interviewed anesthesia as an anesthesia provider and they're relying on other scientists. Anesthesia is a very the only people who understand anesthesia is anesthesia. Surgeons. We always joke in the OR, like, you don't even know what I'm doing. Like, just leave me alone. And they're working right there with us. I mean, don't get me wrong.
You guys are a special group.
There's exceptions. Some surgeons are really, they take the extra step and they try to understand our field and really get it. But, my point is that if you don't have a full orb of the complexity of the anesthetic exposure that you're giving a patient, then you might take the approach of let's just biohack it. Like the brain, you can biohack everything. Let's just biohack the brain. But you really do have to build that solid foundation. You can't biohack if the foundation isn't, if your gut's trash.
Yes.
So you can take your cerebral icin if you'd like, but how's your, your gut?
Right. How's your LPS levels? Yeah. It's poisoning your brain.
I was trying to say that, except I was going to say it dyslexically. So I'm glad you said it.
No, so let's talk about that before we close. What are some of the mainstays that people should be thinking about to really optimize their resilience in case they need to have some kind of anesthesia?
Right. Yeah. That's a great question because preparation is the key. And the thing is, I hear a lot of people are like, well, I didn't have time to prepare now. What do I do? There's still a lot you can do. The foundation of preparation is still the foundation of recovery. I mean, you're not going to biohack in recovery. You're going to start by putting the cement down or, pouring the foundation on your house before you start putting up the fixtures. So even if you're post-surgery, it doesn't change the fact that you still need, like you were just saying it, the gut health, the nutritional health, the circadian health, the hormone health. Those are still applicable post-operatively. Ideally, preparation keeps you from the unwanted side effects and the hit to the brain. But if you don't have that, you do it afterwards, and you get a good community around you. But my perfect world is, and the way I'm designing the programs around all of this, because I am building programs to help walk people through this, is 6 months. 6 months preparation. Yeah, we could do longer, but I think 6 months is reasonable. 3 months before, if you have to, 3 months after, you still have to be proactive on both ends of it. Like you've taken the hit, you've built your resilience ahead of time. You built your foundation. You've taken the hit. Now we've got some environmental stressors to mitigate. Maybe it's the anesthesia. Maybe it's, I don't know. Maybe it's a moldy hospital. That happens.
Yeah, for real.
Seriously. Maybe, who knows? Whatever that outcome is, maybe there's some things you have to environmentally manage afterwards. So you always have a prep period and a post period. My ideal is 6 months before. But 3 months is still good. I always take the approach, and in the book I even take it, it's good, better, best. Right.
I love that.
Do the best. Well, that's actually 9 months to a year, but can you really prepare surgery that long ahead? Maybe you just found out you want to have it or need it. If you want to have it, you have the luxury of time, right? And I'm not telling you not to have it. Get your bleph, get your facelift, But if you care about your brain, then also keep the beauty of your brain intact as well as the beauty of your face, and take the time to make those efforts to prepare like you're running a marathon. Because surgery is basically is that. We call it a surgical marathon. It does the same kind of stress to the body. So 6 months is ideal. Longer, of course, better. And then 3 months at minimum recovery afterwards. Intentional, targeted recovery.
I love it. I'm not speaking from any experience that you have, but I would say just from what I've seen with patients, I completely agree. And I love that good, better, best, because there is a lot of fear around it. I see your comments. Yeah. I see people freaking out. And sometimes I hold my breath when I see your posts. I'm like, this one's going to be I'm glad to meet you in real life because you're a tough lady. But you've taken on a big challenge here in trying to have this conversation with people because it's just become so normalized. Yeah. It's like, it's no big deal. Just have your whatever and you'll be fine. And I'm really glad to hear you say that there's something you can do.
Yeah.
There's always something you can do.
And it falls in the construct of people are already proactively taking care of their health. now, their functional medicine doctor is really ready to walk them through. I just need to give them the tools to understand anesthesia and navigate it. So you're already primed in that field to take on this and help walk alongside patients the way we do in functional medicine. And we're talking about changing the trajectory of a generation of brains. This is a big, I know it's a noble cause and maybe I'm an idealist, but that is what I want to do. I want to change the entire infrastructure around an approach we have around protecting the brain in one of its most vulnerable points. Yeah, we're talking about dementia. There's all this new study that said we can reverse dementia. But how about we prevent it?
Yeah, 100%.
How about we save your suffering and your dollars before it even happens? And if surgery is a big impact and it's cumulative, that's one area we can definitely make a big change. And that's my hope. So.
I love it. I'm with you. Where can people find you?
Oh, yeah, thanks. I'm on Instagram, Facebook, both Beyond Brain Health is my handle.
Okay.
And then I have beyondbrainhealth.com that has all the information about the NSRI and research. And if you want to connect with me on group settings and things like that, that's in there. And we are launching some programs coming up here to support that, to kind of take the framework, break it down for people, because I do feel like that makes it easier as a person who's been a patient. And a lot of other things that we're trying to build, other tools to kind of walk alongside people. But
in the book, I got it off Amazon, but is there anywhere special you want to send people for that?
Oh, no, Amazon's fine. Yeah.
Amazon,
yeah.
okay.
I'm self-published.
Oh, you are?
Yeah.
Good for you.
Yeah, thank you.
I love that. I want to self-publish, and everyone always tries to talk me out of it.
You should. You have a lot to say.
I do.
And a lot of experience.
I got a lot on my mind.
I don't know where you'll find the time, but you should do it.
I love it. I love it. I'm so glad you came on. I'm so glad you came out here to do this live in the studio, and I'm glad to meet you, and I'm really excited about the work you're doing.
Well, thank you so much. I appreciate you having me. It's been fun. I could talk about this all day.
We'll have you back.
Awesome. Let's do it.
Yeah, thank you. Thanks for listening to the Dr. Tina Show. This is a Wellness Loud production produced by Drake Peterson. Theme song is by John the Guilt. You can watch the full video version of this podcast inside the Spotify app or on YouTube. As always, you can email the podcast at podcast@drtyna.com. That's DRTYNA. And if you like this episode, please rate, review, and subscribe on your favorite podcast app. You can also find all of my offerings on my website at drtyna.com. For more shows by my team, go to wellnessloud.com. See you next time, and thanks for listening. This podcast is for general informational purposes only. It does not constitute the practices of medicine, nursing, or other professional healthcare services, including the giving of medical advice. I am a doctor, but I am not your doctor. No doctor-patient relationship is formed. The use of this information and the materials linked to this podcast is at the user's own risk. The content on this podcast is intended not to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.